We've got 11 presentations this afternoon. In my opinion, some of the best work that you'll see presented at the conference. We are not biased. And we're going to ask that everyone stay to time, and we will be somewhat strict just because we do want to get through everyone and give everyone the opportunity to present in their allotted times. So with that, and for people who attended our workshop yesterday, this is going to be an encore presentation of our global guidelines for viral hepatitis service delivery in prisons, presented by Yumi Sheehan.
Thank you so much, and thank you so much for the opportunity to present today. As Nadine was saying, this is a little bit of an encore presentation, but I'm excited today to be presenting on the global guidelines for viral hepatitis service delivery in prisons, which launched yesterday at our UNSW Prisons workshop. And I'm presenting this work today on behalf of my co-authors. So we have no conflicts of interest to declare related to this work. So I wanted to start out by some acknowledgements because these guidelines were prepared by many, many people. They were led by the UNSW Prisons Executive Committee alongside a team of people with expertise in viral hepatitis care, so key opinion leaders including clinicians, researchers, service providers, consultant and policy advisors, peers and advocates from across North America, Europe, Australia and Africa. And these guidelines really were a labour of love and a product of collaboration and teamwork. But I would also really like to especially acknowledge our wonderful project lead, Nadine Crumfley, and our project coordinator, Akil Garg, who were the driving forces behind the work. I'd also like to acknowledge and thank the members of the consumer organisations and the drug user organisations who also participated in the development of these guidelines, and they're listed up here on the screen. So just to set the scene a little bit, there are around 11.5 million people in prison globally, and prisons have an overrepresentation of minority and marginalised populations. And this includes people from poorer socioeconomic strata, foreign nationals, and people who inject drugs, and many people who have complex health needs. The Mandela Rules stipulate an equivalence of care principle. That is, that people in prison should enjoy the same standard of healthcare as is available in the community. But there are challenges to implementing healthcare in the prison sector, and this hinders adequate access to care. So prisons are settings with high viral hepatitis incidence and prevalence, with ongoing injection drug use and sharing of limited and unsterile injecting equipment being key risk factors. But despite this high prevalence, prisons are rarely prioritised for viral hepatitis care, and there is variable access to prison-based viral hepatitis services globally. So in recognition of the high disease burden in the setting, the WHO identified prisons and people in prisons as key priorities for global viral hepatitis elimination efforts to achieve the 2030 targets. And so following in the footsteps of Australia, which developed national consensus guidelines on the management of hepatitis C in prisons, UNSW Prisons identified a need to develop global guidelines to benchmark viral hepatitis service delivery in prisons and deliver on the WHO's elimination goals. So the objectives of these guidelines are to present a critical analysis of the evidence that supports viral hepatitis delivery for people in prison, and to make recommendations for best practice standards in viral hepatitis, so that's A, B, and C, service delivery in the global prison sector. But for the purpose of this presentation today, I'm going to focus primarily on recommendations relating to hepatitis C. So in terms of methods, we followed an adapted version of the WHO standard guidelines development methods. We underwent a 5-stage development process, and that's from planning the scope of work, identifying the working group members. We undertook a systematic review of the literature. We developed the recommendations and accompanying text for each domain. We rated the recommendations according to the grade process, and we developed a full document and sought endorsement from key sector organisations. So the guidelines were formed around 8 key domains. These encompass policy, testing, treatment, continuity of care, prevention and harm reduction, education, minority populations and special considerations, and monitoring and evaluation. 8 expert working groups were established, 1 for each of those domains, and it was important to ensure that we had 3 people in each working group to allow for consensus to be reached within those working groups. And together, we all formed the author group. Members from the World Hepatitis Alliance and Input also participated in the development of these guidelines to ensure that the inclusion of community perspectives were apparent, and they did this by reviewing and providing feedback or input into both the recommendations and the full guidelines document. We then conducted a systematic review to inform the evidence base of the recommendations. A search was conducted in Medline, Scopus, Embase, and Central for all publications relating to hepatitis A, B, and C, and prisons. We identified 8,396 articles. After removing duplicates, we screened 3,992 titles and abstracts. We excluded 2,944, and we were left with 1,048 articles for inclusion in the review, which we sorted into their respective domain and provided these to each of the working groups for consideration. So next up was phases 3 and 4, which is really where the heart of the work happened. And this is where each working group reviewed the evidence that related to their domain and drafted recommendations and prepared a narrative style review of the literature to accompany those recommendations. Then, over a series of 5 meetings, the full author group discussed at length each recommendation, and we refined the wording of each recommendation. And then we rated the quality of evidence and strength of recommendation by consensus as a full author group. And this was done according to the grade process. And ultimately, 30 evidence-based and best practice recommendations across the 8 domains were developed. So these are the grade categories, which we rated each recommendation for quality of evidence and strength of recommendation. So from high quality of evidence down to very low or expert opinion, and strength of recommendation either being strong or weak. And grading, as I said, was achieved by consensus. Okay, so now I'm going to walk you through some of the recommendations, and I'm going to pull out some of those, just a few that I'm wanting to highlight for you today. So the first domain is policy, and we have 2 recommendations here recommending availability or existence of a policy and implementation plan for viral hepatitis services in prisons. So next is testing, and there are 4 recommendations in the testing domain, and these include universal opt-out testing for hepatitis C and B, which should be adopted upon entry for all newly incarcerated people. And by this, we mean testing for everyone upon entry to prison within 24 to 48 hours of incarceration. In the treatment domain, there are 6 recommendations here, including evaluation of DAA treatment, which should be done in the shortest time possible. And this is because of the short stays and frequent transfers which are common in the setting. And evidence shows that streamlined assessments and pathways to treatment initiation increases treatment uptake in the prison. We also have a recommendation that people in prison should have repeat testing at 4 weeks post-treatment to determine cure, i.e. SVR4. This strays away from international guidelines which recommend SVR12, but given the high positive predictive value of SVR4 and SVR12, and this coupled with the frequent transfers and short stays in the setting, we recommend SVR4 for the prisons. So in continuity of care, we have 6 recommendations, and this includes that people in prison, people released from prison while on DAAs should be provided with the remainder of their treatment course at release. And by remainder, we mean all of their remaining treatment to support treatment completion. There are 8 recommendations in prevention and harm reduction, and this includes that high coverage hepatitis C treatment should be implemented to promote a treatment as prevention effect. And by this, we mean high numbers of people with hepatitis C are initiated on treatment to reduce the prevalence and incidence in the setting. We also recommend high coverage prison needle and syringe programs should be implemented, monitored, evaluated, and refined. So we know that this is a substantive recommendation, but the first step really is to implement the PNSPs and then monitor, evaluate, and refine as needed. So I've included the next 3 domains on the same slide. So for education, we recommend that whole of sector prison-specific education programs for hepatitis B and C are implemented. And by whole of sector education, we mean not only people in prison, but all stakeholders in the sector. So that's also officers, healthcare providers, and so on. And for minority populations, and special considerations, we recommend that the specific needs of women, transgender people, ethnic and racial minorities, people who use drugs, men who have sex with men, and sex workers should be considered in viral hepatitis care. There's a dearth of research in this area, and this recommendation provides us with an opportunity for all of us to get more involved in this space. And finally, there are 2 recommendations for monitoring and evaluation domain, which relate to regular monitoring of prevalence and incidence and evaluation of testing, treatment, and prevention uptake in the sector. And then finally, we also sought endorsement of the guidelines from key sector organisations, and we obtained endorsement from the 7 organisations listed here. So these guidelines were developed to galvanise global efforts to prioritise people in prison for viral hepatitis care, and we wanted to do this by coordinating a global approach to prison-based elimination with consistent policy, practice, and reporting. So we hope that you can take these guidelines home and use them in your country or in your jurisdiction to advocate for changes in services that you have in your setting, so that we can have a unified and global approach to provision of viral hepatitis services in prison. So we recognise that many of these recommendations may be more feasible to achieve in high-income countries than in low- and middle-income countries. And so in recognition of this, one of our next steps is to adapt the guidelines to better apply to low- and middle-income country settings. We'll be establishing a stakeholder group to support this, and so if anyone in the audience is interested in becoming a member of that or part of that stakeholder group to inform the LMIC version of the guidelines, please do reach out. And another important step in the next year will be to develop key performance indicators that relate to the recommendations to ensure that a global approach is indeed unified. So here we are. Here are the guidelines. So you're able to access the guidelines via this QR code. They're also available on our Inchu Prison's website. So I do encourage you to become familiar with the recommendations and the guidelines document as a whole and to disseminate them amongst your networks. We have some printed copies, I think, of the 30 recommendations. They're coming. So please do come and find us after the session if you would like a copy of the 30 recommendations. And again, it's been such a pleasure to officially launch these global guidelines at Inchu this year, and we look forward to working together to reach prison-based elimination worldwide.
Fabulous talk. We have 30 seconds for any one burning question. All right, I will ask the question. So Yumi, this was a labor of love, as you said. It was a one-year journey. I'm curious, if you could do it all over again, what would you do differently?
You know, we actually did, I feel like we did a really great job. This was really the work of a lot of collaboration, and we had some great experts who were involved in this space. You know, if we could have done this differently, maybe we would have been able to expand a little bit more to low and middle income countries, you know, up front. But that's something that we're looking forward to doing kind of in the next round, to be able to really focus on the LMIC setting.
Thanks so much.
Thank you.